Our first speaker for tonight is Dr. Jamal Al-Qumati. He is an assistant professor in hematology at King Saud bin Abdulaziz University for Health Science at National Guard, Ministry of National Guard. He's a consultant adult hematologist and stem cell transplanter at King Abdulaziz Medical City in Ministry of National Guard Health Affairs in Riyadh. He has completed his fellowship in hematology in the Royal College of Physicians, Edinburgh, and also in UK. He has many research activities, he has many publications, and he has many poster presentation as well as oral presentation at local and international conferences. Dr. Jamal will give us an overview of aplastic anemia. Dr. Jamal, you have 20 minutes, please.
Assalamu alaikum. Thank you, Dr. Atman, for the introduction, and also would like to thank Novartis for giving me this opportunity to share with you my topic. And my task, I guess, will hopefully lay the foundation for the next two presentations after me. So hopefully in 20 minutes, I'll talk about an overview on aplastic anemia. So aplastic anemia, as we all know, it's a fairly rare and heterogeneous disorder. It's defined as a pancytopenia with hypocellular bone marrow, and that's in the absence of any abnormal infiltrates or marrow fibrosis. Now, if you are interested in history of medicine, probably you need to know that the first case of aplastic anemia was described as such by a German physician, Paul Ehrlich, and that was in a pregnant woman at that time who died of marrow failure in 1888, and further post-mortem workup in the bone marrow revealed the hypocellularity, and that's what's described first. Not till 1904, when a French physician, Anatole Chauvin, prescribed the term of aplastic anemia. Then later on in the 1930s, the distinct entity of aplastic anemia start to be used by that time. So how common the disease is? Aplastic anemia is a rare disorder, and the majority of patients, nearly 80% of patients, are idiopathic, and the remainder are mainly of inherited bone marrow failure syndromes. The incidence is 2 to 3 per million per year, and that's in Europe, but higher in East Asia. And one of the reasons for being higher in East Asia, actually, there was an increased number of patients with aplastic anemia among the American soldiers during the Second World War. And it's thought that time that's probably secondary to using the anti-malaria prophylaxis at that time. Now, the disease has biphasic distribution with a peak at 10 to 15-year-old. And another peak later on in life when the age above 60. There is an equal sex ratio, which is 1:1, male to females, and that's based on most of the population-based studies. And interestingly, half of the cases of aplastic anemia usually occurs in the first 3 decades of life. Now, there are 2 peaks of disease among ages here. So what I'm showing you here is 2 sets of data in Seattle and in NIH, and both show the increased incidence between the 15 to 25 years, with the median age of 20 in the Seattle set of data and 25 in NIH. But there are other important differences between the 2 categories of children versus adults, as the children usually diagnosed less than 16 years of age, while the peak among adults goes up to 25, and obviously, as I said, another peak above 60 years of age. More than 25% of children affected do have genetic origin, while the genetic association or origin in adults is fairly uncommon. Now, treatment-wise, in the children group, nearly 90% of patients They have a survival after stem cell transplantation, while in adults, unfortunately, the transplant-related mortality is quite high, especially above age of 40, and that can reach nearly 50%. And that's obviously why we tend not to transplant patients with aplastic anemia when they are above 40. So this disease classified according to the etiology to inherited and acquired groups. Inherited usually reach about 20% of patients, and the remainder 80 are acquired. Now, in the inherited group, it could be a global hematopoietic effect, so there will be effect of all cell lines, and that's typically what we see in Fanconi's anemia, dyskeratosis congenita, Shosman-Diamond, Berson syndrome, and familial aplastic anemia. However, in another set of patients in the inherited group, only one cell line can be affected, as what we see in the Diamond-Black anemia, or the neutropenia and the severe congenital neutropenia, like in Costman syndrome. Sometimes the platelets are affected, so we see the congenital A megakaryocytic thrombocytopenia, or the other disease is the A megakaryocytic thrombocytopenia with absent radii. Talking about the acquired aplastic anemia, 70% of those are usually idiopathic, with 10 to 15% can be secondary. And we all know the secondary causes of aplastic anemia can happen due to drugs, typically of antibiotics, such as chloramphenicol, the well-known old days antibiotic. Some chemotherapy can be responsible as well. Radiation exposure, infection, especially hepatitis viruses, pregnancy, and autoimmune diseases are all other causes for secondary acquired aplastic anemia. Now, there's another classification with the disease that's according to the severity. So basically, when we define the aplastic anemia and we say it's hypocellular bone marrow, so in the severe aplastic anemia, the bone marrow cellularity should be less than 25%, or it can be 25 to 50%, but there should be at least or less than 30% of residual hematopoietic cells, in addition to the presence of 2 of the 3 following criteria. Neutrophil count should be less than 500.5, platelets should be less than 20, and the reticulocyte count less than 20. For the very severe, the same criteria for severe, but the neutrophils should be much lower, of less than 200. Now, if the patient does not match the severe or very severe, that will be the non-severe or the moderate type of aplastic anemia. So this classification based on the disease severity. The mortality in aplastic anemia is an important issue, of course, and it's been reported that in the severe and the very severe aplastic anemia, the 2-year mortality rate can reach up to 80% if the patient was only in supportive care alone. So he did not have whether immunosuppressive therapy or transplant. Infection definitely is another major cause of death, and the thrombocytopenia will be responsible, obviously, for the bleeding, especially into major organs. However, there are main prognostic factors which does help to have an impression or a guess that this patient at high risk of mortality, and one of them is the older age. So the older patients of age, the higher risk of mortality. Severity of the disease is another factor. If the patient already went on treatment but he responded poorly, that is another indicator of the poor prognosis of the mortality. Plus, if the patient at any stage, sustained a major bleeding history in another organ. Now, the pathogenesis of aplastic anemia, there are 3 main mechanisms. Obviously, they work together. And the first one, which is well studied, is the autoimmune mechanism, and also the direct injury to the hematopoietic stem cells. And as I mentioned earlier, in the secondary causes of aplastic anemia, if the patient has been exposed to radiation or any drugs consumption, chemicals usage, or history of viral infection. The third mechanism is the bone marrow failure related, and that can be in the inherited bone marrow failure syndromes or the clonal evolution in the acquired type of aplastic anemia. Now, the pathogenesis of aplastic anemia, as I said, the immune-mediated process is one of the important mechanisms. And this cartoon, hopefully you can see it fairly clear. So basically what will happen here, once the hematopoietic stem cells has been exposed to any environmental insult, be it viruses, drugs, radiation, there will be immediate T cell proliferation with the oligoclonal expansion. And with this proliferation, there will be a release of the cytokine inflammatory mediators such as tumor necrosis factor or interferon gamma. And that is with the deficits of the hematopoietic stem progenitor cells will lead to the bone marrow failure by two mechanisms: by increase of the apoptosis, programmed cell death, or the reduction in the proliferative and differentiation capacity. The deficits in the hematopoietic stem cells will occur in the form of the shortening of the telomere length and also reduction in the life cycle checkpoint genes. Adding to all this mechanism also, there will be a reduction in the T regulatory T cell function, a reduction of the NK activity, and the reduction also in the mesenchymal stem cell function. These normally suppress the immune status. So with the lack or deficiency of these cells, the immunosuppression will be less. Therefore, there will be like a boost or increase in the immunogenic activity. Now, it has been studied, and I think it's evidence-based, that there's a potential influence of the HLA polymorphism. So HLA alleles has been found, some of them will be associated with the increased susceptibility to aplastic anemia, such as the column on the left-hand side, while some other alleles will be associated with decreased susceptibility. It's not only the incidence of the disease or decrease, but also HLA alleles are also being linked to the response to immunosuppressive therapy. As an example, for example, HLA-DR B11501, that will be associated with increased susceptibility to infection. At the same time, it has an impact on the response to the immunosuppressive therapy. So there are different HLA allele genes which can be associated with whether increased susceptibility to the infection or decreased susceptibility, and also it may have a role or impact on the response to treatment. It's not only the HLA polymorphism, but also the some genetic and molecular abnormalities has also been documented. For example, on the table on the left-hand side, some cytogenetic abnormalities like monosomy 7, trisomy 8, 6-PUPD, with different incidence percentage, do have a prognostic impact on the outcome of aplastic anemia patients. On the right-hand side table, some of the molecular mutations, also with different incidence, has an impact on the prognosis of the disease. Without going into details of this because of the sake of time, just to mention, for example, the highest incidence of molecular mutations like BCOR or BCORL can reach up to 9%, and that has usually a favorable response with improved progression-free survival. On the other hand, the ASX1L1 with the incidence of 6 to 8% does have poor prognosis with the inferior progression-free survival to the outcome of the disease. So the message here is probably identifying these mutations or these cytogenetic abnormalities will give a clue or hint to the expected prognosis or outcome. So the clinical manifestations of the disease, that's basically or simply related to the cytopenias the patient will suffer. So there will be recurrent infections in the patients due to neutropenia, bleeding tendency due to the thrombocytopenia, and symptomatic anemia due to anemia. I think the bleeding tendency and symptomatic anemia interferes more with the quality of the patient's life, patients with aplastic anemia, while recurrent infection does have risk of mortality and the the outcome can be drastic. And because of this, I would like to share with you 20 years ago data from MD Anderson when they looked into their aplastic anemia patients between 1994 to 2000, so a period of 6 years. They looked into their aplastic anemia patients and the outcome or the survival after the sustained infection. As you can see from this Kaplan-Meier curve, clearly there is a superiority or a survival in the patients who cleared the infection completely, while on the dotted line, which I hope you can see it, this represents the patients who were not able to clear the infection, and definitely the outcome was poor. Now, compared their group or their study to a meta-analysis of different other data, basically the mortality on all these meta-analysis studies, the mortality due to infection in aplastic anemia ranged between 26 to 100%. In MD Anderson group, it was 56%. And the average of this mortality, I think, turned out to be like 55%. So it's quite a big percentage of patients that are at risk of death due to infection. Also, this meta-analysis showed the organisms responsible for the infection, probably bacterial infection, are the highest. That's followed by the fungal infection, and the third by viruses. Obviously, some patients do have infection with multiple microbes, including bacterial, fungal, and viruses as well. But the highest incidence of infection is due to bacterial infection. So the evaluation of patients, the first question, do you need to admit the patient? I'm talking about the newly diagnosed patients of aplastic anemia. Do we need to admit the patient, or can be managed outpatient? And the simple answer is this: it all depends on how bad the cytopenia is. So with the critical cytopenia, and if the patient has higher risk of threatening complications such as infection or bleeding, then ideally the patient should be worked up as inpatient. While with the patients with milder cytopenias, no clinical, obvious clinical complications or no specific increasing risk of infection or bleeding, patients can be managed as an outpatient. The evaluation of the patient, we normally start with the history, of course, and I'll just mention here that we need to focus on the exposure from the history, any exposure, previous exposure to drugs, chemicals or viral infections, and family history plays a major role in working up the newly diagnosed patient with aplastic anemia. Clinical examination should focus again on certain aspects. Just showing you some slides here of the skin affected in aplastic anemia patients. So skin can be affected in the form of hyperpigmented areas, as you can see. Nail dystrophy or nail changes also is there. Skeletal abnormalities, especially short stature, should be taken into consideration, and also proper or meticulous or detailed examination of the eyes and genitourinary systems should be done. As you can see from this slide, retinal hyperpigmentation with the retinal hemorrhages are associated with this disease at presentation. The clinical manifestation will be even more important when we're talking about the inherited syndromes. We do know that the short stature, the microcephaly, developmental delay, the skin and fingernail dystrophies, all are important signs need to be elicited and detected in a newly diagnosed patient. Now, the diagnostic workup, the most important two things normally we start with is the peripheral blood smear and bone marrow. The blood smear usually will show whether normocytic, macrocytic anemia, in addition to the evidence of neutropenia, thrombocytopenia, but it's important to make sure that there are no abnormal circulating plas or blood forms. Typically, the bone marrow biopsy will reveal an empty bone marrow from any hematopoietic activities, and that is replaced by fat spaces. The British Committee for Standards in Hematology in 2016 published the guidelines on managing or approach to patients with aplastic anemia. And the first list of investigation, these are the routine tests, and I'm sure all of you know it, and all of us, we're doing it. But I'm just highlighting the comment made then that there were tests, they were not routinely done at that time. I'm talking about 2016, but they expected that should be a routine in the next few years, and actually that's what we're doing now. For example, the peripheral blood leukocyte telomere length, so which is useful usually for screening of telomere gene mutations, next generation sequencing, and single nucleotide polymorphism are also probably a routine test now done in most of the tertiary referral centers. But please bear in mind that you see patients of aplastic anemia in district general hospitals or primary care hospitals, and bear in mind that not all these tests are available everywhere. Now, the differential diagnosis of the disease, as I said, the work should be done by the proper history, clinical examination. Then you run the baseline laboratory tests, but usually the disease is diagnosed of exclusion. Why is that? Because as we can see from this cartoon here, the aplastic anemia does have an overlap with other hematological disorders, especially the hypoplastic MDS, PNH, large granular lymphocytic leukemia, and also the dyskeratosis congenita and other syndromes. Sometimes even AML, acute myeloid leukemia. So all these conditions has to be excluded. Therefore, a multidisciplinary team approach is recommended to arrange for all these tests and to confirm or to rule out the other overlapping condition. This is just a table to show the overlap between the aplastic anemia and myelodysplasia. And in this setting, myelodysplasia can be de novo or hypoplastic MDS, or even post-aplastic anemia MDS if the patient has presented late. I think it's important to know the differences between all these syndromes. For example, the age distribution, the dysplastic change shouldn't be absent. For example, any morphological dysplastic change should be absent in aplastic anemia. Fibrosis shouldn't be there. And so on. So these are just to give you an idea about the overlap of these syndromes, and maybe one has to do like a checklist to check all these variables or factors. This is, I find this diagnostic algorithm very simple and very informative. This is done by or published by Professor Bashigalupu in Blood in 2017. So if the patient presented with pancytopenia, I think as a clinician, it's your role from the history to try to exclude other conditions like myelodysplasia, leukemia, or metastatic cancer by history. Then you need to proceed to the bone marrow biopsy and aspirate, where all the tests on the cytogenetic fish and molecular needs to be done. And also in the peripheral blood, you may need to run all the tests to rule out other causes for hereditary bone marrow failure syndromes. Once you're satisfied with the acquired aplastic anemia diagnosis, then transplant should be considered if the patient fulfilled the criteria. Therefore, HLA typing should be done at baseline.
Next 2 minutes, Dr. Jamal, 2 minutes.
Yeah, I'm finishing actually. So the next step will be the treatment, which will be done in the next couple of speakers. The just specific presentations of the aplastic anemia during a pregnancy. As we know, this can be challenging, and meticulous monitoring and adequate support therapy is given because the outcome can be basically poor in pregnancy, and all women should have frequent assessment during pregnancy. Also, association of the hepatitis with aplastic anemia, which is about 10 to 15%. It can be only mild, with no further progress of the disease, but there was one case report here published last year, which basically the presentation was so aggressive, and the patient needed to go for stem cell transplant with the background of hepatitis. Now, I was asked to include any current guidelines in the management in the approaching aplastic anemia patients. So I looked into the last 10 or 12 years, and probably the most comprehensive guidelines is the British Society Hematology, where they published the adult aplastic anemia approach in 2016, and amendment done on 2018 for the pediatric group. There are other recommendations done by the European Group of Blood and Marrow Transplantation. Italian Fanconi Anemia Registry also has published some recommendations. Aplastic anemia in China registry and the Korean Society also published guidelines on the management of aplastic anemia. A group of American endocrinologists published published recommendations on the management of the endocrinopathy in Fanconi anemia patients, and also an international expert in myeloid disorders group published criteria to distinguish between MDS, AML, and aplastic anemia. So to conclude, aplastic anemia is a rare disorder that affects mainly men and women equally, and the autoimmune damage to hematopoietic stem cell is an important contributor to the most cases of aplastic anemia, in which no underlying cause is clearly identified, or what we mean by idiopathic. Significant differences in the etiology and treatment outcome between pediatric and adults is also known. Aplastic anemia has diverse causes, and the urgency of clinical evaluation and the bone marrow biopsy is guided by the depth of the cytopenia, and that's the main indicator where to work the patient as inpatient or outpatient. And aplastic anemia should be distinguished by clinical evaluation, laboratory studies, and bone marrow examination with specialized testing from other causes to rule out other causes of bone marrow failure. And I think this is my slide, and thank you for your patience with me. Thank you.
Thank you, Dr. Jamal, for this excellent overview. Our next speaker for tonight is Dr. Philip Schimberg. He is the head of division of Hematology, Hospital Beneficia Portugues, Sao Paulo in Brazil. He's also a staff clinician, hematology branch at National Heart, Lung, and Blood Institute, National Institute of Health, United States. He has hematology and oncology fellowship training in the National Institute of Health, also in the United States. He is certified in internal medicine, medical oncology, and hematology. And he also has Doctor of Philosophy from Department of Pediatric, University of Sao Paulo School of Medicine. He has more than 90 scientific publications. He has more than 60 abstract presentations in scientific meetings. He has a significant number of participation as an author of book chapters. He has been a principal investigator in many clinical protocols and guidelines. He has several prizes in his life, and he also is a peer-reviewed ad hoc for many medical journals. And he also has more than 400 lectures in international conferences. Dr. Philip will talk to us tonight about non-transplant treatment for bone marrow failure. Dr. Philip.
Thank you very much, Dr. Ayub, for that kind introduction, and thank you for the lecture just before mine, since it really summarized a lot of important aspects in aplastic anemia. I thought it was a really good overview in 20 minutes. It's a pleasure to be back talking to the Saudi Society for Blood Disorders. I had the pleasure to address the society last year, and I'm very happy and pleased that I was invited back to talk about this important topic on non-transplant therapy for bone marrow failure, and we will be discussing aplastic anemia. So I had a really good introductory lecture, so that helps me in building what was developed in terms of therapeutics. Here are my disclosures, and this was mentioned in the prior lecture, so we still use age as a very important discriminator to decide if somebody with severe aplastic anemia either goes to transplant if they have an HLA matched sibling donor, and if they're young, or if they're older than 40, or don't have an HLA matched sibling donor and they're younger, they should go to immunosuppressive therapy. So age is a very principal discriminator. And why 40? Because several people have showed that patients over the age of 40 tend not to do as well with transplantation in aplastic anemia. So older people or people without a donor HLA matched sibling donor family, IST, younger with an HLA matched sibling donor, transplant. IST is mostly employed in the world because most patients don't have an HLA matched sibling donor, and it's more accessible. And what we have learned from several trials is that response to immunosuppressive therapy is critical for survival. So here's a curve in patients who received IST and responded to immunosuppression, and long-term survival, you can see over many, many years, 5, 10, 15 years, is over 80%. Contrast that to those patients who don't respond to immunosuppression. So response to immunosuppression is a very important surrogate for survival in this disease. Several trials have actually investigated ATG cyclosporin, mainly horse ATG cyclosporin, across several continents. And the overall response rate is about 60 to 70%. So we learned from these studies across 20 years that about 2/3 of patients, or 60 to 65% of patients, respond. And this correlates with a better survival, as I have indicated. So we still have a problem here that 1/3 of patients don't respond to immunosuppression. And I will be addressing those patients. Several things have been tried to improve the response rate above 60% or 65%. G-CSF have been tested in 5 prospective randomized trials. They were negative. Mycophenolate mofetil, which is a third immunosuppressant, so horse ATG cyclosporin plus MMF, did not get better responses. Rapamycin, which is another immunosuppressant associated with ATG cyclosporin, so again, a 3 immunosuppressant drug regimen, was no better than horse ATG cyclosporin alone. And keeping patients on cyclosporin for longer really did not improve their response rate. It probably delayed the relapse rate, but patients eventually relapsed as you tapered the cyclosporin. So nothing has actually improved beyond horse ATG cyclosporin. This is 20 years worth of data. So other approaches was to give more potent lymphocytotoxic therapy to destroy and to get rid of more lymphocytes, because as was shown in my previous talk, this is seen as an autoimmune disease. So you have autoreactive lymphocytes that recognize and destroy the bone marrow. So immune-mediated aplastic anemia is treated with immunosuppressive therapy because it is an autoimmune disease like lupus or rheumatoid arthritis. So this was shown in the prior presentation. So different forms of immunosuppression have been applied. Unfortunately, none of these worked, but rabbit ATG was tried. Rabbit ATG is more potent. It gets rid of more lymphocytes and causes a much more profound lymphodepletion for much, much longer. Patients can become lymphopenic for months after rabbit ATG, not after horse. Horse, the lymphocyte counts go down and go up in 2 weeks. So in 2 weeks, the patient will recover their pre-treatment lymphocyte count. With rabbit ATG, it can take months. Alemtuzumab or Campath, same thing. The lymphocyte count drops and they stay low for a long time. So the idea is that giving more lymphopenia, more lymphocytotoxicity, we would get more responses. So this was a prospective randomized trial comparing 1:1:1. The standard was horse to rabbit ATG or alemtuzumab, which was thought to give a better response rate. So if horse ATG was going to give a 60%, the trial was designed to give an 80% or higher response rate with rabbit or alemtuzumab. Before I show you the overall results of these trials, cyclophosphamide actually was tried back in the 70s. Very toxic, but some patients responded. It causes a profound myelosuppression, neutropenia. This was studied at the NIH in the 1990s, a lot of mortality associated. And then 8 years later, another trial was done using voriconazole to avoid fungal infections, but still the mortality fungal infections was really, really high. So cyclophosphamide is associated with a lot of toxicity. So it's not really applied. Patients stay 60, 70, 80 days with zero neutrophils. So it's a very hard therapy. Some patients can respond if they don't die from the therapy, but it's not widely applied. So let's talk about these other lymphocytotoxic strategies. Unfortunately, the hypothesis that rabbit would be better than horse was not proven. Alemtuzumab was even worse. It was not giving good responses in this trial as first-line therapy. But as you can see here, and this was published online in the British Journal of Hematology, looking at all the studies that compared horse and rabbit in terms of response, several prospective trials, and all of them show that horse was better. This one, this one, this one. This one was ours at the NIH. This was EBMT. This was a Chinese study. And there's a Russian study, actually, that was published in abstract form only, which was never published in a journal, but showed the same thing. And if you look at several of the retrospective studies, you can see that the majority shows a superiority for horse ATG. And there are two meta-analyses, actually, that includes all these studies, and both meta-analyses with almost 1,000 patients, or 1,400 patients, if you combine both meta-analyses, shows a superiority of horse serum versus rabbit serum. The problem is that horse ATG is not widely available all over the world like rabbit ATG is. It is available in the United States and some parts of the world, but not everywhere. Latin America, for example, where we are in Brazil, we have to import it. It's not widely available. So, but it is a better immunosuppressant. It's not a more potent immunosuppressant, but it's enough to give responses. So the treatment options, as you see, for aplastic anemia. Now, I did discuss horse ATG cyclosporin, rabbit ATG cyclosporin, alemtuzumab. There is some Brazilian experience showing that alemtuzumab can be beneficial in some groups. So we presented this as an abstract at ASH, small study, but larger studies haven't reproduced this. And I've shown you that rabbit is not as good as horse, alemtuzumab not as good as horse. Androgens is widely applied. We don't know, it has never been systematically studied, but we think that the overall response rate is about a third. Some reports are higher, 40%, but it's all retrospective, no prospective controlled trial. So we don't have a good number for androgens. What we do know is that in patients with short telomeres, as was brought up in the first talk, there are patients with telomeropathy, very, very short telomeres with aplastic anemia. We did a prospective trial in very short telomere aplastic anemia patients, and the response rate there was very high, 80 to 90%. So we know that androgens can be beneficial actually in a subgroup of patients. Transplantation can be curative. The problem is that you need a donor, matched, related, or unrelated. And more recently, we have heard from haplotransplant, but far fewer experience. There is a 5 to 10% transplant-related mortality, and there's the risk of acute and chronic GVHD. So that's inherent to the transplant. And we know that older patients have a higher risk of mortality compared to the younger patients for transplantation. So you can see here that if you're over the age of 40, you have almost a 50% mortality 2-3 years after transplantation. So that's pretty high. That's why we go to IST over the age of 40. And if they don't respond, you might consider transplantation. And this is true for unrelated transplants. There's a very strong correlation between age and survival. And in the last 10 years, the TPO agonist, thrombopoietin receptor agonists. And I'll talk more about Eltrombopag because there's more experience with Eltrombopag, although there is some more recent data with romiplastin. And keeping patients on cyclosporin for longer doesn't really increase the response rate. And we've tested that prospectively, and that wasn't shown to be beneficial. And it is associated with continued toxicity. So I discussed briefly a lot of these other options, but let's talk about the TPOs, because I think there's some interesting data here to discuss. So when we were developing these trials, we were discussing all these different immunosuppressive therapies, you know, mycophenolate and G-CSF and cyclin. Nothing seemed to give more immunosuppression, didn't seem to be better. So we changed the strategy of giving a drug that potentially stimulated the bone marrow. And what does that mean? We know that patients with aplastic anemia have a deficiency in stem cells. So they are deficient in stem cells. And the problem is, even if you get rid of the autoimmune attack, the stem cells that are residual from the patient, they have to recover. The problem is, if there's so much destruction, the patient may never recover, even if you take care of the autoimmune attack. And some patients have more of reserve, and they probably have a better probability of recovery. The problem is, how can you increase this stem cell number? Several studies have been tried with stem cell factor, combination of G-CSF and EPO. Nothing seemed to have worked. The question when TPO was approved for ITP in 2008 in the United States for a different disease, immune thrombocytopenia, the question is, could stimulating thrombopoietin pathway stimulate stem cells? We were skeptical about this approach for several reasons, but we ended up doing the trials. And I'll tell you why we were skeptical. We did the trials in second line, patients who failed IST frontline. And to our surprise, actually, we started seeing some responses, which led to approval by the FDA in second line, approval by the EMA in second line, and then the FDA approved in frontline in 2018. And there's been approvals in frontline in several countries around the world, including Anvisa, which is our Brazilian FDA, which approved Eltrombopag in frontline in combination with IST. So I'm going to show you 2 slides, the rationale, and then I'm going to show you the data that led to these approvals. What is the rationale? TPO, or thrombopoietin receptor, is expressed in hematopoietic stem cell. Well, that's interesting. If you look at GM-CSF, or EPO, or G-CSF, they're not expressed on the stem cell. They're expressed in more committed progenitor cells. But TPO is expressed in stem cells. And we know that people who work in stem cell biology, they use thrombopoietin in vitro to stimulate stem cells, along with FLT3 ligand, stem cell factor, and other cocktail cytokines in the medium. And we know that mice that are deficient in thrombopoietin, they have reduced platelets, they have reduced megakaryocytes, but they also have reduced stem cells. So in an animal model, thrombopoietin is important to maintain stem cells. And in vivo, as was mentioned in the first talk, there is this entity called amegakaryocytic thrombocytopenia, where TPO is not functioning, thrombopoietin is not functioning, and these kids develop, now we're talking in humans, develop thrombocytopenia. And if they live long enough, they develop multi-lineage marrow failure. So thrombopoietin in humans is important to maintain stem cells. The problem is, and this is why we were skeptical, in aplastic anemia, if you measure thrombopoietin in humans with aplastic anemia, the level is sky high. It's off the roof. This is like measuring erythropoietin in a patient with MDS, right? If it's way high, and if you give erythropoietin subcutaneously, the anemia is probably not going to improve. So we were concerned about the endogenous, already high level of thrombopoietin. How much more thrombopoietin can we give to overcome this already high level? So we were skeptical about this approach. But we have studied several immunosuppressive regimens, and none of them seem to be better than horse ATG cyclosporin alone. So we decided to add this to the armamentarium. How did we do it? We started at 50 milligrams, single agents, in patients who failed IST, and we went up to 75, 100, 125, 150. Why did we go up to 150? Because we wanted to overcome this high level that the patient already had. Why did we stop at 150? Not because of toxicity. because we already giving a high dose and we weren't sure if that could bring consequences to the patients. Remember, we're talking about 10 years ago, 11 years ago, when the doses for ITP were 50 and 75. So we were the first ones to give 150. So we were a bit concerned. So we stopped at 150. So we did a pilot study with 25, 26 patients. It was published in the New England Journal. This was extended with more patients, 43 patients, second line, single agent. And the response rate was surprising, 40%. So 40% of patients who actually failed IST responded to this oral outpatient regimen. We were wanting to have an increase in platelet count, but we were surprised to see hemoglobin go up, even leukocytes going up. So we were seeing bilineage and multilineage responses. And many patients went off transfusions of those who responded. And it was a very well-tolerated outpatient regimen. The toxicities that we saw were the ones seen in ITP. Headache, myalgia, sometimes some rash, upper respiratory symptoms. We were concerned at the time of fibrosis. We were concerned about thrombosis, but we didn't see any of that. No thrombosis and no fibrosis in these marrows. And we did marrows. We did biopsies at 0, 3, 6, and 12 months. That's in the first year of therapy. 4 bone marrow biopsies. That's a lot, but we didn't see any significant increase in reticulin. Here's some examples of some of these early responders. You see that patient number 1 was a patient who started with me at the NIH. He was getting transfusions every Friday. He failed every protocol. He failed cyclophosphamide, he failed MMF, he failed lintuzumab, and he was transfusion dependent. And we put him on this protocol, and you can see that his platelet count went up very, very nicely after a few months. This is patient number 1. And if you look at patient number 1 here again, he had a hemoglobin of 7.58, and you can see here in blue that his hemoglobin went up to 16. So we were starting to see multilineage responses to a drug that we thought was stimulating the megakaryocytes, but we were getting a sense that we were stimulating a more primitive hematopoietic progenitor cell. And another indication of that was bone marrow cellularity, pre-Eltrombopag, post-Eltrombopag. So you get a sense that you are repopulating this marrow in a way that is something that has never been achieved before, hitting a very progenitor cell. This is a follow-up study that did not have the ramp-up. It was not 50, 75, 150. It was 150. We started at 150 because that's the dose that we thought was active, and we gave it for 6 months. The prior trials were giving for 3 months or 4 months. Here we gave 150 from day 1, 6 months. What was the result? 15 out of the 40 patients responded by 3 months, and 20 out of the 40 responded by 6 months. So 50%. Not too different from the 40%, a little bit higher. Probably not statistically significant, but what was impressive was the robustness of a response, the complete response. So more patients had complete responses, meaning that more lineages that were going up, more CBCs or hemograms are getting normal. Why robustness of response is important? Because we know that the more robust the response, the higher the likelihood that you can stop Eltrombopag. So of these 20 patients, 19 had a robust response, and in 15, Eltrombopag was stopped. And many of them tolerated discontinuation. So having a robust response is good because, first of all, you go off transfusions, your counts are getting better, but it gives you a higher chance of stopping Eltrombopag, which is something very, very interesting. So these patients don't have to be on Eltrombopag for the rest of their lives or forever, especially if they have a robust response. So now we're seeing that Eltrombopag is probably stimulating the stem cells, but we know from the ITP literature that Eltrombopag also has some immunomodulatory mechanisms. It increases regulatory B cells, increases regulatory T cells. It decreases inflammatory cytokines, as was shown in the first talk. to be part of the pathogenesis of aplastic anemia. And it also breaks down iron chelation. So it's a drug that probably has several mechanisms of action, and in the aggregate, it's improving bone marrow function and hematopoiesis and blood counts in these patients. So going back to that curve, it is possible that Eltrombopag is increasing this number of stem cells and increasing the probability of recovery of these patients. So here is all the studies of Eltrombopag in second line, mostly retrospective, some prospective studies. This again published in the British Journal. You can see that the responses vary between 40 and 60%, around 50% if you take the average. You can see that some responses are a bit higher with romipilsine, but keep in mind that romipilsine included moderate aplastic anemia patients, a lot of moderates, not only severe. So the populations are not exactly the same. And Eltrombopag was moved to frontline in combination with ATG cyclosporine. And this is the data down here that I'm going to show you in the next 4 or 5 slides, and it's going to be the last piece of data of this presentation. So what was the trial? Well, you get the 2 drugs that, horse ATG cyclosporine, and you add 2 drugs, immunosuppressant, and 1 drug to stimulate the bone marrow. This is a 92-patient study, about 30 patients in each cohort. And in cohort 3, all 3 drugs were started simultaneously on day 1. We did not do that in cohort 1 because we were worried about toxicity, giving too many drugs at the same time. But we learned from these cohorts 1 and 2 that the drugs were well tolerated. So in cohort 3, which is about 30 patients, all 3 drugs were started at the same time: horse ATG cyclosporine, Eltrombopag at 150, and given for 6 months. This was a non-randomized trial, single arm. And when you look at cohort 3, the overall response rate was about 90%, with a complete response rate of about 50%. And this was compared to a historical comparison of hundreds of patients where the complete response rate was only about 10%. So this was a big difference that we saw. And as I mentioned to you, that there's a very strong correlation between response and survival. More responses, more survival. So at the time of publication in the New England Journal, median follow-up of 18 months, the survival was over 95%. Clonal cytogenetic abnormalities was a concern for this trial. So these bone marrows were done frequently. And what we learned is that we did not see an increase overall incidence of clonal evolution in this trial as compared to historical. And any cytogenetic abnormality was defined as clonal evolution, even if they were benign in nature. And we learned that there are high-risk cytogenetic abnormalities that involve chromosome 7, as was mentioned in the first talk, that are associated with increase in blast, dysplastic findings, loss of response, and these patients usually have to go to transplantation. But there are other cytogenetic abnormalities, as was mentioned also in the first talk, like trisomy 6, deletion 5q, that were counted as clonal evolution, that have no dysplasia. Sometimes they are transient and go away, and the patients have a complete response or a partial response. So these we call of undetermined significance or low risk. So this is a very important distinction. High-risk cytogenetic abnormalities, low-risk cytogenetic abnormalities. These data were updated in 2020. 176 patients were treated with horse ATG cyclosporine Eltrombopag. Overall cumulative 14%, but that includes everybody. But when you look at a high risk, we're talking about 6% only. And this is almost a 3 to 4 year median follow-up. So a number that is relatively low compared to what we have seen historically, and the survival still remains over 90% after a median follow-up of 4 years now with ATG cyclosporine Eltrombopag. And if you're a responder, a partial or complete, that number is even higher, 95%. So there are a lot of algorithms now incorporating Eltrombopag in front line with immunosuppressive therapy, which particularly seems beneficial in adults probably less beneficial in children. This is an algorithm that I'm not going to go through it, that includes some of what I showed before and the high and low risk cytogenetic abnormalities and some transplantation rescue regimens that might be considered in patients who failed initial therapy. There is a prospective EBMD randomized trial that was conducted in Europe. I don't think Saudi Arabia was involved. I think they might have included patients. This is a randomized trial comparing horse ATG cyclosporin versus horse ATG cyclosporin Eltrombopag. And what was shown is that the 3-drug regimen was superior at 3 and 6 months when you look at overall response. A was 2 drugs, arm B was 3 drugs. And you can see that the overall and complete response rate was superior with the ACE regimen, ATG cyclosporin Eltrombopag. We're waiting for this data to be published. This was an EBMT trial ran by Regis Perfor de la Tour, Carlo Dufour, and Antonio Risitano. And my last bit of information, for those of you who are going to be at EHA, we ran a phase 2 single arm trial doing Eltrombopag plus cyclosporin, no ATG, just 2 drugs, outpatient regimen. This will be presented as an oral at EHA. I'm not going to go through the details of the trial, but it's for severe aplastic anemia in patients who can't get ATG or too old to get ATG or an access to ATG, comorbidities, all kinds of reasons. 2 drugs, Eltrombopag plus cyclosporin. 1 minute, I'm done. 6 months was the primary outcome, and the primary outcome was overall response rate, complete or partial. Here are the 54 patients that are included in this trial. You can see that the mean was 52. More than half the patients had an ECOG greater than 0. So there was an older population. I can't present the data because the data will be presented at EHA in a few weeks. Just to remind that Eltrombopag has to be monitored in terms of liver toxicity. As you see in IST, only 10 to 15% of patients in the aplastic anemia trials had significant elevations of their LFTs, does not have renal impairment, and in East Asian patients, the dose has to be reduced by half. So as a single agent, 40 to 50% response rate in second line. In front line, 3-drug regimen, better than the 2-drug regimen. So giving 2 immunosuppressant and Eltrombopag is a better regimen for aplastic anemia frontline therapy in those patients who are not undergoing transplant as their first line of therapy. So I summarized a lot of data, including very recent data to you all. This is our group in Sao Paulo, Brazil. This is my email, and I'm happy to answer questions. You can send me email. I'm happy to interact. I'm very I like these interactions and learn from the experience from other groups. Thank you very much for your time and for your kindness and for the invitation for being here once again.
Thank you, Dr. Chemberg, for this nice presentation. We'll move now to the third presentation for tonight, and our speaker will be Dr. Naif Al-Juhani. Dr. Naif is a consultant hematologist and stem cell transplant at King Faisal Specialist Hospital and Research Center in Jeddah. He's the head section of adult hematology and bone marrow transplant. He did his fellowship in blood and marrow transplant in the United States and adult hematology fellowship in Canada. He has American board and Canadian board in internal medicine. He has many research and publications. He will talk to us tonight about transplant therapy for bone marrow failure. Dr. Naif. Dr. Naif, you can unmute yourself.
Yeah, sorry, do you hear me?
Yes, go ahead.
Okay. Okay, thank you, Dr. Othman and the SSPD for the invitation. So I'll be talking in the next 20 minutes about transplant therapy for bone marrow failure. And my overview of the presentation, I'll start with historical aspects of transplant for bone marrow failure. Then we'll talk about progress and outcomes over the last few decades. And then I'll mention a few preferences and studies on why transplant is preferred over immunosuppressive therapy, although Dr. Rosanna made it more difficult, and review the published results in this regard. And then I'll talk about indications of bone marrow transplantation. And then we'll have a few slides about the types of conditioning in aplastic anemia, and also a few slides about peripheral versus bone marrow source of stem cells, and then we'll finish with summary slides. This is an interesting paper which was published in 1970 by Dr. Borton. He summarized all the cases of aplastic anemia that were transplanted before 1970. There were about 45 cases. And as you can see on the left side of the screen, the types or the etiologies of having aplastic anemia, which kind of interesting to me. This include excessive exposure to radiation. As Dr. Jamal mentioned in his first presentation, chloramphenicol was another one common at that time, benzene exposure, etc. And the age is variable from pediatrics up to the age of 65. All of them received allogeneic transplant. I believe at that time there was really no good HLA matching. So they tried to use different techniques like ABO compatible, kind of same sex, etc. But unfortunately, all those patients actually did not have any kind of chimerism, and they had no engraftment and died. So just give you the perspective from history at that time. But over the next few decades, in the 1970s and 1980s, there was a significant improvement in the bone marrow transplant procedure in aplastic anemia, and in general, I believe. The first paper on the left side compared the bone marrow transplant to ATG in the treatment of young patients with severe aplastic anemia. That was published in 1980, and they describe 35 patients who had HLA identical sibling donor, and they compared them to those who did not have a donor, so they received ATG. And the 2-year survival improved to 72% compared to 45%. There was another paper in the pediatric group that also looked at the data from 1977 to 1987, and the outcomes were about 70% overall survival. Then Dr. Andrea Pacherupu summarized the outcomes in the EBMT database. He published the paper in 2000 that included, 3,669 patients transplanted between 1976 to 1998. And he also mentioned and showed how the outcome improved with survival approaching the 80%. And this is also another paper from EBMT that show how the survival has improved dramatically over the years. Now in 2021, overall survival approach essentially sometimes 100%, but it's usually in the range between 75 to 95%. This is also taken from the CIBMTR, and as you can see, the improvement comes with time in the survival. This paper summarized the different studies that used transplant in related and unrelated setting between 2000 and 2015 or 16, and all the studies showed an excellent outcomes in general with a good overall survival ranging between 80 to 95%. When it comes to ATG plus cyclosporin, although there has been also remarkable progress in the outcomes, but historically, they used to have inferior outcomes compared to transplant for the young patients. And that's why transplants was preferred over immunosuppressive therapy in those who are young adults who have a match-related or unrelated donor. The second thing which you have to keep in mind that immunosuppressive therapy for aplastic anemia can result in higher clonal evolution compared to the bone marrow transplant, ranging between 6 to 11%. When it comes to age, again, there is a clear differentiation between the different age groups. Younger patient has much higher survival compared to those more than 40 years of age. And that is also the same for those who receive immunosuppressive therapy. In this slide. When it comes to the type of donor, match-related donor, they have a favorable result compared to the unrelated donor. This is a slide taken from the CIBMTR, which summarized the allogenic transplant for severe aplastic anemia for those aged more than 18 years. And as you can see, the match-related donor, they have around 83% long-term cure compared to about 77% for the unrelated donor. This is a paper just published last year by measu, and it really summarized, it's a meta-analysis that have looked at more than 15 studies, and they clearly show the benefit of hematopoietic stem cell transplantation compared to immunosuppressive therapy as a first-line treatment for severe aplastic anemia. That's the graph on the left side. On the right side is the failure-free survival, which means the relapse risk of aplastic anemia was also in favor of transplant compared to immunosuppressive therapy. So that's just, this table summarized the previous slides. It seems, or it's shown in those studies that overall survival appears to be better with allogeneic bone marrow transplantation, at least in the long-term setting. The transplant has a higher failure-free survival. All-cause mortality, including transplant-related mortality or treatment-related mortality, has improved significantly over the last 5 to 10 years in transplant, and now they are around 5% to 10% maximum, if not less. And clonal evolution, as we showed in the previous slide, appeared to be higher in the immunosuppressive therapy group compared to the bone marrow transplant group. In terms of indications, as I think Dr. Jamal mentioned, the criteria for severe and very severe, usually we take patients to transplant if they have severe or very severe aplastic anemia, or in general if they become transfusion dependent. As the professor mentioned in his previous slides, there are certain high-risk cytogenetic abnormalities that you have to be checking and following up in your patients, just to make sure the patient does not harbor one of those high-risk abnormalities, because they are associated with poor outcomes and higher risk of clonal evolution. And preferably, they should go to transplant earlier than later, because if they develop MDS or leukemia, it becomes more difficult to cure them. Moving to the conditioning chemotherapies, I summarized this in this slide. I tried to summarize most of the studies that looked at conditioning. So you have the 3 separate parts, match-related. The original conditioning that started was single agent cyclophosphamide, 200 milligram per kilogram. Then ATG was added later. And that became the standard of care as a type of conditioning chemotherapy for severe aplastic anemia for the young and fit patients. Later, fludarabine came and was included in the regimen, the FCA regimen, or the fludarabine cyclophosphamide ATG. And when you add the fludarabine, the cyclophosphamide dose goes lower, and that's the idea. The idea is you want to create a less toxic regimen. High dose cyclophosphamide of 200 milligram and more is toxic, and it might lead to higher transplant-related mortality of 10 to 25%, and other complications, including hemorrhagic cystitis and viral reactivations. So that's really triggered investigators to look for a less toxic regimen that has comparable results. And the FCA was found to be comparable, if not slightly better in terms of overall survival compared to the Cy-ATG. In the match-related setting, essentially the same kind of conditioning, but likely you need to add a TBI to the regimen. EBMT experience showed a higher rate of graft failure of 17 to 18% as published by Pichalupu, and it appears adding TBI to the related setting can reduce the graft rejection and lead to better outcomes. And later, the haploidentical transplant came in the last 5 to 10 years, and the famous protocol that I think many hematologists know is the Hopkins protocol, with the PTCY that use ATG, fludarabine, and low-dose cyclo with the TBI, with the post-transplant cyclo for day +3 and day +4, that showed 100% overall survival, 100% engraftment, and very mild acute and chronic GVHD at 10 to 12% only. This is another paper that looked at the different conditioning regimens published by Nelly Benjian in Blood Advance in 2019. And they found that flu-Cy-ATG, as you can see with the dotted red line, is comparable to the Cy-ATG, the usual standard of care, in terms of overall survival. And when it comes to age, they found that an age of less than 30 was a differentiator in terms of survival for patients who received those regimens. In terms of Fanconi anemia, just on one slide, originally this is started in Seattle group with a single agent cyclophosphamide, low dose, 60 milligram per kilo. And then the French protocol added the TBI low dose 400 centigrade to the low dose cyclophosphamide to improve graft and reduce graft rejection. KFSH Real had their experience. Mohabi has published his experience adding ATG to the low dose cyclophosphamide with a total of 60 milligram per kilo. And that resulted in generally, right now, Fanconi anemia can have an overall survival of 80 to 88%, which is an excellent for such a group of patients, with a TRM of 8 to 18% across different studies. Haplo protocol also came in the Fanconi, and that is also the same thing with the Hopkins protocol. They use much lower doses of fludarabine, cyclophosphamide, and ATG, and that also resulted in 1 year overall survival utilizing the Haplo protocol in Fanconi anemia around 72.6%, but there was a much higher risk of severe reactivation and hemorrhagic cystitis as expected in this vulnerable group. Moving to the stem cell source, bone marrow continued to be the standard of care. Those two major studies that looked at this question and set the standard for the aplastic anemia stem source. As you can see on the left, patients separated into less than 20 years old versus more than 20 years old. The best survival, the A graph is for the graft versus host disease, and as you can see, there was a higher probability of chronic graft versus host disease in those who receive peripheral blood compared to those who receive a bone marrow, with the best outcomes seen in those who receive bone marrow and less than 20 years of age, with a probability of chronic JVH of around 12%. If you look down, the panel B looked at the probability of overall survival, and as you can see, also bone marrow for less than 20 years patients has a probability of overall survival of 85% compared to 73%. So that's almost about 10% difference in survival if you use peripheral blood compared to bone marrow. That was also seen in another study that also found that bone marrow harvest as a stem cell source leads to 80% survival compared to 76% at 3 years. And this study did not show a benefit of GCSF primed bone marrow. This is a paper by Rajat Kumar published 3 years back. He looked at the question of bone marrow versus peripheral harvest based on demographics and economical factors. And he found that best outcomes were seen in USA and Canada and high-income countries. HIC is high-income country, and LIC is low-income country. With USA, Canada, bone marrow was clearly better compared to peripheral blood in the States and Canada. But what was interesting, if you look down at panel D, in low middle income countries, the peripheral blood appeared to have better results, but likely the explanation may be related to late referral for transplant in this group in those low income countries. Maybe they are heavily infected more than the patients in USA and Canada, and maybe heavily alloimmunized. And maybe in this group, peripheral blood can lead to faster recovery of count and kind of prevent complications related to transplant. And maybe that's why you see higher peripheral blood survival compared to bone marrow. But just keep in mind, in those both peripheral blood and bone marrow in low-income countries are lower than the figures in USA and Canada and high-income countries. This slide just shows you how things have changed in terms of the choice of the donor and the stem cell source over time. And this is taken from the EBNT database. What's interesting, if you look at the sibling bone marrow and sibling peripheral blood, it seems lately, over the last 10 years, the curves plateaued. So there was no higher peripheral blood compared to bone marrow. But when you look at the unrelated setting, the peripheral blood continued to rise. And the paper mentioned that maybe this is related to the choice, because this is a related patient, donor, so maybe preferring to use a peripheral blood, which you cannot control really. And that's maybe the reason why you have a higher unrelated peripheral blood stem cell source. And also on panel D, there is a rising of haplo bone marrow and haplo peripheral blood too. In summary, transplantation success for bone marrow failure patients with MRD has improved considerably over the past 3 decades, with 75 to 95% chance of long-term cure. MRD transplant is recommended as a first-line treatment for young and adult patients who are indicated for transplant. The upper age limit, especially now in 2021, continue to be controversial. Someone who is fit, has no comorbidities, you cannot really say, like at the age of 40, you cannot give them transplant and just use immunosuppressive therapy. I think it depends case by case. So someone who is very fit and has really no comorbidities, it might be preferred to offer them transplant for long-term cure. Cy-ATG and the flu Cy-ATG are the standard preferred regimens. And during the last 2 decades, the outcomes of allotransplant for aplastic anemia patients with the MUD also improved significantly. And the haploidentical transplant in bone marrow failure is an emerging alternative that has excellent outcomes with very low TRM and should be considered if there is no match-related donor or agent MUD available for indicated patients. And bone marrow harvest remains to be the best source of stem cells, but peripheral harvest can be used if resources are limited or patient is heavily alloimmunized or severely infected. And that's the end of my presentation. Happy to take your questions. Thank you.
Thank you very much, Dr. Naif, for this excellent presentation. Now I'd like to have the three speakers with us for a few questions. Can you unmute yourself, Dr. Chimberg, Dr. Jamal? Well, we have only very few questions. The first one says, asking about a pediatric patient with aplastic anemia waiting for bone marrow transplant. Developed platelet refractoriness with platelet transfusion not responding to IVIG and methylprednisone plus pulse doses. Started with Eltrombopag 50, now day 8 on Eltrombopag, but no response. Platelet only 4,000 to 5,000 with episode of epistaxis. Would you suggest to go for high dose of Eltrombopag more than 50?
So waiting for transplant, meaning I'm not sure if the patient was diagnosed and the transplant is the first treatment option, or if the patient got IST and then is waiting for a transplant. But platelet refractoriness, allosensitization or alloimmunization is a big problem in aplastic anemia for transplant, because we know that historically these patients have had a higher rate of rejection, given a lot of transfusions that patients have had in the past. So this could be a really high risk of graft rejection. Now, we've had patients who had allosensitization, platelet refractors, HLA antibodies, and haven't grafted with peripheral blood and a lot of stem cells infused. The patient is, how old is the patient? We have given 50 milligrams is okay. Depending on the age and the weight of the patient, you can try going higher to 75 or even 100 milligrams. Kids over the age of 12 or higher can get 150 milligrams. Between 6 and 11, you can do 75 or even 100 milligrams of Eltrombopag to try to improve that platelet count. The problem is going to be this platelet refractoriness, alloimmunization in the setting of bone marrow transplantation, because this will increase the risk of rejection of this patient.
Well, his second question is about the role of Eltrombopag in Fanconi's anemia.
That's a great question. So when we started looking at the responses in acquired aplastic anemia, I have actually tried to incentivize the company and several investigators in Europe and the United States to try to look at hereditary forms of aplastic anemia, like dyskeratosis congenita or Fanconi anemia, because you don't have really that many options for these patients, except giving the androgens for the blood counts. You can transplant them, but then you fix the marrow, but you have all the extramedullary carcinomas that can happen 5, 10, 15 years later. There are clinical trials ongoing trying to investigate this exact question, so we don't have data, very few patients treated. There is an interesting aspect of Eltrombopag in Fanconi, because one other mechanism of Eltrombopag is it has some DNA damage repair mechanism that might be beneficial in Fanconi anemia. So I know that anecdotally, there's been a few patients who actually responded, but we have to look at larger number of patients in trials to see if it actually has activity for the hereditary forms of aplastic anemia.
Another question for patients with non-severe aplastic anemia. When do you start thinking to initiate treatment, and what would you start with?
That's an interesting question, because the non-severe aplastic anemia is a less well-defined group. It's a heterogeneous group, and there's no really standard. You can just observe the patients. If the patients are not doing too well, if they're doing well and don't need transfusions, you can give a little bit of epogen or erythropoietin or G-CSF, or sometimes you can give cyclosporin. I know that some people give danazol. We had a trial at the NIH using an anti-CD25 monoclonal antibody, the daclizumab. So depending on how severe the counts are, you might want to just wait, give a little bit of transfusion, try cyclosporin alone. If the counts are tending towards severe, you might want to treat that patient as more with like 21,000 platelets. The cutoff is 20. You may want to start thinking about treating that patient with ATG cyclosporin. And if they're starting to get to the severe range or drifting down, you may want to start preparing them for that algorithm. One last note I'd like to make, though, there's a lot of patients, not a lot, but there's a good number of patients who have moderate aplastic anemia, and they stay stable for many, many years, who actually have a higher chance of having a telomere disorder or a short telomere length and telomeropathy, and a higher propensity and a higher chance of responding to androgens. So there's no standard of care for aplastic anemia. I know that there's a trial that was published by the NIH using Eltrombopag single agent in moderate aplastic anemia, 50% response rate. The Germans are doing a study comparing cyclosporin versus cyclosporin plus Eltrombopag in moderate aplastic anemia. So it's a bit of a mixture of patients, heterogeneous group, and several things can be tried. It's unlikely that this patient will have a life-threatening complication if their counts remain in the moderate range. And I've observed patients for years with moderate aplastic anemia without doing nothing. So it all depends on where the counts are.
Right. Another question, is there any animal research to induce JAK2 mutation in severe aplastic anemia? Then this may promote myeloproliferation that might help?
So animal models for aplastic anemia have been very, very hard. I know I have a paper in Seminars of Hematology which discuss all the attempts of designing an animal model for aplastic anemia for decades, and none of them seem to reproduce the human phenotype. But at the NIH, there was an animal model that was actually closest to that, in developing an animal model for aplastic anemia to study several things, but they did not involve JAK2 manipulation. They involved haploinfusions of cells to create an immune-mediated destruction. So as far as using JAK or the JAK pathway, I'm not aware of a model that is exploring that to reproduce the aplastic anemia disease in a model.
Another question, patients with bone marrow failure with monocytosis and isolated severe neutropenia, but normal cellularity and cytogenetics, what would be your approach?
Keep in mind that there's this entity that with monocytopenia, decreased myeloid monocyte precursors, it's been described at the NIH in some patients who have significant monocytopenia and some warts, mycobacterial infections, to have a GATA2 mutation. So I just mentioned because this is something that is not really characteristic of immune-acquired aplastic anemia. But if the patient has isolated neutropenia and normal platelet counts and normal hemoglobin, I would investigate for LGL, large granular lymphocytic leukemia, because I think that could be a strong possibility. If the marrow is not hypocellular, I don't know if the marrow is pan-hypocellular in this patient, but usually it's unusual for you to see aplastic anemia just with isolated neutropenia. I would probably think of other things. Now, it could be that the isolated neutropenia started and then the platelets started to drop and then the reticulocytes start, and you can have after a few months pancytopenia. That's possible. But if somebody's stable, isolated neutropenia, I would probably think of other things that could be involved, like LGL. We got several patients referred to us as aplastic anemia, and we checked for LGL, and sometimes it's positive. And then the algorithm for treatment is a little bit different.
Another question, maybe to Dr. Naif, what is your recommended conditioning for PNH aplastic anemia?
Well, I mean, it's the same essentially. So we use the same kind of protocol like those without PNH, even those non-myeloablative protocols like the Hopkins protocols included patients with PNH, and there was a cure of those patients with the eradication of the PNH clone. So it doesn't make really a big difference in the choice of conditioning.
Right. There are maybe 4 questions asking whether the aplastic anemia can be transformed to acute leukemia. Is there a spontaneous recovery? And is there a possibility of inheritance of aplastic anemia if the father or mother has aplastic anemia? Maybe
yeah, so there's, yeah, I'll answer all 3.
Okay.
So if that's okay?
That's
okay,
okay.
okay. So there is inherited forms of aplastic anemia that can be passed on. to the child. So if somebody has Fanconi anemia, it's not unusual for you to see other members of the family that have, or even dyskeratosis congenita. So if you have a genetically defined aplastic anemia, you can have the hereditary transmission of the disease. So that's number one. Number two, there is a small percentage of patients who can start with immunoplastic anemia that can develop into MDS, high-grade MDS, and leukemia. That's the minority of patients. If you take it all clonal evolutions, which is defined by any cytogenetic abnormality, even includes those that are benign, you're talking about a 10 to 15% rate over 10 years that was presented in my presentation and in others. But if you look at the high risk, which is the ones you worry about, and that's the leukemia, you're talking about a 5, 6, 7% rate over a long period of time. So the bad news is that these patients have to go to transplant. There's really no standard of care. You know, the good news is not the majority. So 90%, 93% are not going to develop this, but there is a small percentage that can develop high risk transformation that we call, and it can involve acute leukemia. I have seen it, unfortunately. It's really unfortunate when you see it. It's not a common occurrence, but it can happen. And I'm sorry, what was the third question?
Is there any spontaneous recovery?
Oh, yeah, that's an interesting question. Usually when if it's immune-acquired aplastic anemia, usually not. But I have seen a few cases where there was a question about a medication that could have been involved. And there was this question, the medication was discontinued. And I've seen that sometimes over the course of 4, 6, 8 weeks, that counts actually got better. So that's a little bit of a drug-induced. But if somebody has a non-drug-induced, nothing-induced, immune-acquired aplastic anemia, it's very extraordinary to have spontaneous recovery. I have not seen it. The recommendation is to treat all these patients, either with IST or transplant, depending on the algorithms that have been discussed. I had a really interesting case who had post-hepatitis aplastic anemia, who had severe seronegative hepatitis, 3-4 months later developed aplastic anemia, and he eventually started to get better over the course of a few months. That is extraordinary. That usually doesn't happen. So if you don't think there's a drug that is associated or an infection that is associated, that you want to wait a little bit to see if this is going to get better, it's okay to wait a little bit, 4 weeks, 6 weeks, but don't wait 6 months, 1 year, because I've seen that happen. 6 months later and people are still waiting forget that. That has to be treated. So a few weeks is reasonable if you have a strong suspicion that there's something that precipitated that. But if somebody has a hypocellular marrow and you excluded other diseases, they remain pancytopenic, severe neutropenia, I would follow the algorithms that were presented in these presentations today.
Othman, if you allow me to ask, can I ask?
Yes, you can ask.
Yeah, just a quick question to Dr. Schamberg. Now, in regards to the TPOs, I know only the Eltrombopag is being licensed or approved in aplastic anemia. But what's your experience on romiplostim if Eltrombopag has failed?
Yeah, so we have actually, I have very few experience with that scenario. Eltrombopag started first. There's been a lot of much more data on Eltrombopag. The South Koreans have actually started investigating romiplostim in 2016, 2017. I went to South Korea 2 times. I saw the data. I saw their trial development. The initial results looked very interesting. They presented at ASH in 2 years. They published in Lancet Hematology. I actually wrote the editorial for that paper. And they published in the British Journal of Hematology, journal in which I am the associate editor. So I was able to follow the romiplostim story. Look, I mean, it shows that there's activity. Interesting that it shows activity at higher doses. So with 1 microgram or 3 or even 7 micrograms, there's very few responses. It was only when they give 10, 15, or 20 micrograms per kilo that you started seeing the responses. That's interesting because in aplastic anemia with Eltrombopag, it's at the higher doses that you seem to see the responses. And if you look at MDS, it's a different disease, but it's only at the higher doses that you seem to see responses with these TPO agonists. So it looks like for marrow failure, you need higher doses, maybe to reach that progenitor cell. But with the romiflozin data, it looks like it's a class effect, right? It's not just Eltrombopag, but it seems to be a class effect. The thrombopoietin receptor agonists seem active. And I'm actually reviewing another paper right now with there's another a thrombopoietin receptor agonist from a different group that is also showing activity in aplastic anemia. So it seems to be a class effect. The romiflozin data included a lot of moderate aplastic anemia patients, so it's a little bit of a different patient population. But it's based on the data, it's an active strategy. They study in second line. I don't think they have that many patients, about 40 or 50 patients if you add everything to date. And I think they're starting to investigate in frontline in combination with IST. I was actually just talking to the Amgen people a few weeks ago. I spoke to them at ASH in 2019 to see if they're interested in developing a frontline trial, but they're still, thinking about it. But it seems to be a class effect of these agents.
Well, the last question, and maybe just we need a short answer. Can we use Eltrombopag as a frontline without immunosuppression while awaiting transfer to a higher center?
Yeah, that's interesting. So we did the Eltrombopag plus cyclosporin data. So that's readily available. That's without ATG. I think so. I think the earlier you can give Eltrombopag, the better. If you look at the NIH trial right now, the current NIH trial is to give Eltrombopag like as soon as the patient is diagnosed with aplastic anemia, because sometimes they don't have access or quick access to a tertiary center or a center that takes care of a patient with higher complexity. So what they're doing is Eltrombopag, boom. After doing the bone marrow, etc., cyclosporin. If they don't respond by 3 months, give ATG. If they respond, keep them on the two-drug combination. So I think based on what we know so far, based on the data, that the sooner you give, the better. So I think that would be a reasonable approach. The question that I thought you would ask me is if you could give Eltrombopag or cyclosporin waiting for a transplant. And I've had that question come from several people all over the world. And some people do that. The problem is if they respond to Eltrombopag and cyclosporin or Eltrombopag, are you going to transplant that patient? I mean, if somebody has 120,000 platelets, 2,000 neutrophils, a hemoglobin of 12, they responded to Eltrombopag, are you still going to transplant that patient, right? So that becomes a little bit of a bridge, complicated. But I think, yes, I think if you have access to the drug and you don't have access to a tertiary facility that can take care of complex patients and you want to transfer that patient eventually, I would do it. I think that would be beneficial to the patient.
Well, at the end, I would like to thank you all, our speakers, for your excellent presentation, to thank our participants for being with us tonight and their interaction with their questions. Great thanks for Novartis company for sponsoring the 3 webinars organized by SSBD, CML, ITP, and today Aplastic Anemia. And finally, great thanks to SSBD, Saudi Society of Blood Disorder, for their efforts to organize such excellent educational activities. And thank you all, hoping to see you soon in another SSBD webinar activity. And thank you very much for everybody. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.